Hello, Kara Vavrosky here from today's RDH. Today, I'm joined by Dr. Petra Wilder-Smith, who is a professor and director of dentistry at the University of California, Irvine. I want to chat with Dr. Wilder-Smith because she was the lead investigator of a recent study which compared aerosol and splatter from coronal polishing with four different handpieces. Out of the four handpieces that were tested, three were cordless and one was a standard air-driven handpiece that attached to the dental unit. Hello, Dr. Wilder-Smith. Thank you for joining me today.
Good morning, Kara. It's a pleasure to join you on this conversation that we're going to have. And I'm looking forward to discussing with you this important study that we did on variables that can affect the aerosol transmitted during dental procedures.
Wonderful. So, aerosols in dentistry have always been a focus in dentistry. However, since the pandemic, I feel that they have really been brought to center stage. Can you briefly describe the recent study you completed focusing on mapping and quantifying the aerosol and splatter generated by the four different dental hygiene handpieces during coronal polishing?
I'd be happy to. Perhaps as a little bit of background, aerosol is particles that are smaller than 50 microns that are emitted during any kind of procedure that causes aerosolized emissions, and splatter is anything larger than 50 microns. That differentiation is important because aerosol goes to different places and stays for different periods of times than splatter. So aerosol is the tiny particles, smaller than 50 microns in diameter. Particles that are particularly important for us are those smaller than 10 microns because they can go directly into the lungs and cause diseases there. Now, splatter really wasn't considered that important until recently, because we thought, well, it's just these bigger particles, they fall onto the floor, maybe they mess up our shoes, maybe they mess up our face screen, but we don't think they do much. That's not true. What happens, for example, with tuberculosis is that we get these aerosolized droplet splatter particles with tuberculosis, mycobacterium tuberculosis, inside them. And the water on them evaporates, they become smaller and smaller, and then the tuberculosis can be airborne later on as it dries out or as there is any kind of movement of the dust or the debris that's on the floor and cause transmission of tuberculosis. So even though they're different, they're both equally potentially dangerous. Now, what kind of illnesses can be spread by aerosol and droplets? Very briefly, we're all thinking about COVID, SARS-related diseases. I've mentioned TB, influenza, measles, herpes, HIV, Legionnaire's disease. It's a long list of diseases. We've all come to think that COVID is what's brought aerosol into our conversation, but actually it should have been there a long time ago. So in this study, we wanted to look at what happens with different coronal polishing handpieces. Is there a difference? Should we be doing this? So we took four handpieces that had different sizes, that could go at different speeds, that had different mechanisms of propulsion, if you like, different mechanisms of causing the concentric movements. And we used them on a simulator, so a plastic head set on a pole in a dental chair with a typodont inside. And we developed a standardized polishing routine to make sure that we were comparing like with like. We had to use very strong white lights, laser lights, sometimes ultraviolet lights. We put non-reflective black photographic cardboard around the whole setup and on the floor to make sure we didn't get false data from reflections. And then we filmed the aerosol that came off during a standardized polishing procedure. And we also recorded photographically what splatter was falling onto the floor, onto the chest of our simulated patient, and onto the face guard of the clinician. The first thing that was really interesting was we found that what happens close to the face is very different from what happens at a distance. When we looked at the variables that were most important, we were also surprised to find that outcomes differed depending on what variable we were looking at. So were we looking at how much aerosol is coming off, volume of aerosol, or were we looking at how far does it go? How long does it stay in the air? Or were we looking at splatter, how much of it goes on the ground, or where does it go on the ground? So we repeated this experiment 240 times.
Oh, wow.
Yeah, it took a lot of patience and a lot of time, but we needed to be sure that all of these unexpected variables were being mapped accurately, because to our surprise, we found that really this work had never been done before. So we repeated this thing 240 times. By the end of it, we were really good at it. And then we looked at our results and broke them down by each of the variables. And none of us expected what we found. The first finding was, of course, that it depends how big the handpiece is and where we hold it in front of the mouth. So we standardized for that. We always had those variables the same, controlled throughout the study so that they were not a factor, but they're relevant. We found that if you look at the speed of the handpiece, we did this study at 2 different speeds of handpiece. Low speed versus high speed is very important. Now, if we say, how does low speed versus high speed affect how far does my aerosol go? Low speed reduces the distance that the aerosol travels by 20 to 30%. So it goes 20 to 30% less far. But if I look at the volume of aerosol I'm pumping out, this is really interesting. The volume of aerosol is reduced by, guess what? 80 to 90%. So speed of this coronal polishing handpiece is hugely important in controlling the risk of aerosol transmitted disease during simulated polishing. So when you pick the hand pieces that you're going to use, when you think about the settings that you're going to use, speed is hugely important. Now, we usually work with some kind of high volume evacuation when we're doing coronal polishing, thinking that, oh, this is the best way of protecting our patient. But actually, yes, it has an effect. I'm going to talk about how much effect in a minute, but it has less effect than handpiece speed. So typically, if I compare using no suction versus HVE at the same handpiece speed, I reduce the distance that my aerosol goes by 50%. If I look at the volume of aerosol that's produced, I also reduce it using HVE by 50%. Wow. Now remember, high speed to low speed gives me 80% reduction. So you definitely should be doing HVE and low speed. Keep in mind, however, we had optimal conditions, right? HVE probably does less in real life. We had a handpiece that was optimally positioned. We had the HVE clamped in place in optimal position, and we weren't moving around. We were polishing in a standardized location. So the accuracy and effectiveness of your HVE technique is also going to be hugely important. Should we move on to Sparta, or did you have some questions on that, Kara?
I don't think I have any questions, but I feel that there's a lot of variables that I think that I don't know if everyone actually thinks of. Like, yes, we use an HVE, at least we should be, especially now. But you don't think about, it also matters the speed of the slow speed handpiece you're using, meaning whether if it's a handheld cordless or if it's attached to a dental unit, how hard you're actually pressing on that rheostat, like the speed matters. And so like for a cordless, is there variable speeds available on that cordless, or is it all just one speed? These are things that I think that maybe perhaps some clinicians aren't thinking about. And just how much that the aerosol and splatter really is reduced it's just wow. It's just kind of like, oh, I had no idea. I think this study is very timely, especially now. I almost feel like it should have been done a really long time ago, as you mentioned. So I guess my next question is, what were the differences among the hand pieces that you tested?
So you mentioned the key word, Kara. You mentioned rheostat and pressing on it. We saw considerable differences between the hand pieces, and yet we were using them at standardized speeds. So I thought, we're using them at the same speed, we're using the same technique, but we saw a difference of up to 60% between the different hand pieces. So we started looking at them, trying to figure it out. And the first thing we found is that those hand pieces where you have to press on them to activate them, you start off from speed 0 and you're developing up to this burst of speed that delivers a cloud of aerosol. So ideally, you want to keep your handpiece at the same speed. Any change in speed sends off this cloud of aerosol, just like when you drive through a puddle when you're driving your car. You start from 0 speed when you're polishing, and boom, the thing powers up, and out comes the aerosol. So the first thing is you want a handpiece that produces a very constant speed during polishing. And we found that even apart from the rheostat variable, those handpieces where we could set a fixed speed, some stayed at that fixed speed better than others. And those were the ones that performed better. So that was one variable. So we have a big engineering lab here. So then we organized that all of the hand pieces turned at the same speed through an external control device that we attached to them. So now they were all, let's say, cranking at 1500 RPM. They still performed differently by about 30%. So we're going, what's with this thing now? So the only thing we could come up with, well, maybe their heads don't all turn in a complete circle, the actual polishing head. That would create more turbulence on the surface of the tooth that's being polished and might have an effect. So we clamped all the hand pieces so that they were polishing a fixed piece of plastic with dye on it, so that we could actually see how circular the trajectory of the polishing is. And indeed, even if we put very similar or the same prophy angle heads onto them, some polish in almost a perfect circle and others don't. And that is associated with turbulence at the surface that you're polishing, and it affects the movement, if you like, the currents or the flow of your aerosol. So that is another important variable. Who knew?
Yeah, I guess I never thought that. I was never a really great in physics in college. And so you never think, oh, I'll be fine in dentistry. If physics isn't my thing, biology is my thing, bacteria, I'm great. But if you think about it, when you go to think about these variables, when you're actually thinking about how a piece of equipment works and that there actually are these variables, I mean, I had no idea. And go figure, this is physics here. It's fascinating. So which handpiece performed best? And again, your thoughts are on why. You've kind of alluded about how evenly it spins and things like that, but give me your thoughts.
The handpiece that performed best was one where you could set it to a fixed speed and it stayed there. One that had a well-controlled speed of about 1500 RPM. We found that was really a good speed to go at. I have a wonderful hygienist who works with us in our group here at UCI. And so as we did this study, I would ask her, well, if we set the low speed to so-and-so, is that a low speed that's going to be clinically useful? Or the hygienist is going to say, forget it, I'm not going to sit here all day doing this. And she felt that 1500 was a good one. And I know some of the handpieces we used actually had a 1500 setting. So we tested 4 handpieces. We worked with a range of handpieces that I thought covered as many different variables in handpiece design and performance as possible. And one handpiece that performed really well was the Premier AeroPro, because it could be controlled really well and its performance was very nicely standardized. So both with regard to distance of aerosol spread as well as volume of aerosol production, it really did nicely. The other thing that we did, we also asked our testers, well, how do these handpieces feel to you? I thought, if we have all these people testing these devices, I might as well pick their brains as much as I can. So we had this whole range of ergonomics questionnaires for them as well. And we go, how does this handpiece feel? Is it comfortable? Do you feel fatigued? What do you think of the size? What's the ergonomics like? And interestingly, the Premier AeroPro also did best on the ergonomics. It was light, it felt one in people's hands, the activation mechanism was good, and on the ergonomic evaluation, as well as the measurement of fatigue after use of the handpiece, it did the best out of all the handpieces that we tested. So this was a fun study because we also had surface EMG sensors on the testers' arms. We had them fill out all these questionnaires. We measured the strength of their pinch and grip after using the device. We really quantified as much as we could in this study. And the Premier AeroPro is a nice handpiece. It did best out of all the ones we looked at, both for ergonomics and for aerosol.
That is one thorough study there. And I do have to say thank you for taking into account to actually asking a hygienist or hygienists what their thoughts are, considering they're the ones that, for the most part, are using these handpieces the most. So thank you about that. I have to throw that out there. So what are some maybe important clinical takeaways for clinical hygienists that you can summarize for us regarding the study?
Well, the first takeaway, I think, is one that you will like and that surprised me and the whole of my team. Perhaps I should mention we have a team of about 50 hygienists who help us with all our testing. There's no point in testing something if you're not talking to the users. So thank you to all of our team of testers. The first thing we found is if you use a coronal polishing handpiece well, it produces almost no aerosol and very little splatter. That's the first thing that surprised us. We thought you'd have to be really careful and et cetera, et cetera. But compared to, let's say, a dental drill or an ultrasonic handpiece, this prophylaxis handpiece produces very little aerosol. Secondly, you need to use HVAC, of course, and you need to use it properly at all times. You need to think about your technique as you do your coronal polishing, because the aerosol that you produce varies a lot from location to location in the mouth. So you need to think about optimizing the positioning of the HVAC at every position, every location, I'm sorry, that you work in the mouth, because the risk, let's say, from the front of the mouth to working at the posterior areas of the mouth is quite different.
I think that really sums it up. Things that, again, I don't think I've ever necessarily thought about when I was polishing a patient. But, things that are kind of interesting to think about that we really do need to know, because we really should be paying attention to aerosols. I think that sums it up. Thank you. Thank you so much, Dr. Wilder-Smith, for your work on this research and for speaking with me today. You've kind of opened my mind to there's some deeper thoughts about polishing, because it was kind of the first thing we learned to do in college and hygiene school in the hygiene program. And so you think, oh, this is just the easiest thing. It's just go around, but really there's a lot to think about. So thank you. And I would like to thank Premier Dental for helping with this video. And then I want to thank everybody who tuned in. You can find the research and check it out at rdh.tv/AeroPro study. That's rdh.tv/AeroPro study. And that's all one word. Thank you again, doctor. And I want to thank everybody for tuning in, and may all of your patients floss.
Love it. It's my pleasure. It's a pleasure to talk to you, and I enjoyed speaking with you today.
Thank you. Have a good one.
You too.